Dear friends and panelists, welcome to Day 5, Session 6 of the IRC. Today's session is about reimagining universal health access in rural India. Here are some of the collaboratives and the Center of Excellence at TRI. We would be sharing more details in the chat box towards the end of this session. We will begin the session with a short video on the IRC theme video of the August Revolution.
जनता का आह्वान किया, वर्षों जकड़ी बेड़ियों को अब तो तोड़ो। क्रांति की मशाल जला गांधी बोले, अंग्रेजों भारत छोड़ो। बहुत सहा गुलामी को अब ना सहेंगे, आजादी की बात रही वो लेके रहेंगे। अगस्त की बेला में हम सौगंध उठाते हैं, सशक्त राष्ट्र के सपने को चलो मिलकर आज सजाते हैं। हर युवा को रोजगार मिले, हर नारी की आजादी हो, हर घर स्वस्थ सबल बने, ये गली गली मुनादी हो। हो, जन जन स्वाभिमानी हो, देश में ना रहे गरीबी, विकास ही अपनी निशानी हो। एक क्रांति फिर ऐसी हो, रगों में वही रवानी हो, कंधे से कंधा मिलाकर सबने बस यही ठानी हो।
Let's have a quick introduction of the panelists by one of my colleagues in Jharkhand, Mr. Shamal Santra. Over to you, Shamal.
Dear friends and fellow citizens, on this evening of 5th August and on the 5th day of the Rural India Colloquy, I welcome to the session on reimagining universal health access in rural India. The conversion conversation that matters to us, the rural community, the Laura Chualis, Amma Annas, Bhaiya Bhatija Juba of the rural India. Therefore, the conversation is about the soul of the India, and truly we're looking for Bharat ki dil ki baat. Dear friends, the Colloquy weeks between 1 and 8th August is also celebrates and remember the 79th anniversary of the August Revolution, the largest mass movement and the freedom and the dignity. Dear brothers and sisters, on the backdrop of this COVID-19, today's session is on the opportunity of the discussion on the focusing on the surfacing answer and the response to the emerging opportunities. During COVID-19, we have saw how our fragile health system could not cope up with the surging numbers. The numbers and the phase of infection took us the dignity even from the dead. Friends, let us mindful that there is no dignity to the human life without being well nourished and being healthy. But unfortunately, the rural India has been left to its own wits of traditional healers, RMPs, occult, and uncertainties. Staying at the edge of the system, the strives one of the basic dignity. Continued morbidity makes her the less productive and the lost wages. In one of my papers, I have chronicled the cry of the pregnant mothers and the newborns. We have witnessed that once this COVID-19 has hit us, the pandemic crowded out all the health services. Millions are forced into the poverty due to out-of-pocket health expenses each year. Our hard-earned achievements and the progress in the maternal mortality, child mortality, vaccination, family planning in recent decades are under challenge. Universal health access is an idea we must implement even when the public policy may not be ready. While we urge to government, if our colonial masters can do the NHS, why can't India? We have an excellent panel today who will be helping us to think through the promise of the UHA. Once this India was fighting with the COVID, at the same time we have also seen the new India has emerged in the rural Indias. We have seen how this women SHGs has came out. Once state was near to failure, how these women SHGs has came out and taking care of their own brothers. How this PRIs at the local level, the leadership has emerged, and with the new technologies, how these youths has come out. And with that, we have experienced a new thing. The new India in the rural Indias, and it has been backed by the new vision, with the young generations and backed by the technologies. And at this situation, it is very essential that all of us, private, public, people and panchayats should work together, and we need the all hands in the deck, and it should not be limited to the past barriers of the public or private areas. We have to make it happen, and the opportunity that has visible during the COVID. We have an excellent panel today with Joy Satya, Professor Joy Satya. We have someone who has combined all the insights required to set the system right. He has guided and seen many national health policies, seen how other countries who started less infrastructure than us, like China, Cuba, ensures the quality health access. Dr. Ajay Nair, who has maybe called as an action man of India, whenever India was faced a challenge, he and his team had helped to breathe India. And with his support in Jharkhand, particularly TRF, we have been able to support that almost 17% of the needed oxygen beds in Jharkhand during the COVID. We have Mr. Neeraj Jain. He has been demonstrated an innovative solutions and partnership with the government at all levels. We will hear the practical ideas and making the system work. We have Dr. Narayan. We have all looked of her to work as a policy analyst and activist. She breathed with Health for All. We are all looking forward to her to guidance and taking charge ourselves and ensuring the health services and health access at the community level. We have Nilimaji hosting this excellent panel visiting fellows of Brookings. She has directly worked in fixing our public health and nutrition system. While at Seva Mandir, she has seen the part of the spectrum. As a head of Vedanta's social responsibility, she had led the largest Anganwadi augmentation program. So with much more words, I will welcome again all of you and taking this session to reimagining universal health access to rural India, and it is handing over to Nilimaji. Please take us through the session. And again with the Bhupen Hazarika song from Assam, that he told that Mor Gaero Simanai Poti Dhuni Suni. So I am hearing a new footprint in nearby my villages. I try to understand that what it is. Chena chena poro, but chini tena paring. So I feel that I know it, but then also sometimes I feel that I can't understand what it is, because in between there are many pahads, means that many rocks are there. So it's up to you that this excellent panel will guide us to understand this, listen and the music of the new emerging India, the rural India, and the new emerging villages. So how we'll take it to the rural areas and our fellow citizens and our brothers, sisters, and mothers. So over to Nilimadi, to you. Thank you very much and welcome again.
Thank you very much, Shamal. I really hope that the panel can match the poetry and the music of your introduction. Thank you very much. And thank you also everyone on the panel and TRIF. I'm honestly delighted and honored to be on this very, very important session on universal healthcare. The most fundamental, if I may say so, one of the most fundamental things which determines almost the entirety of the rest of human well-being. So thank you very much, and a warm welcome to everyone on the panel and to the participants for making time for this session. So as you all know, universal health coverage is part of the 17 SDGs. Considered health itself is an important part amongst the 17 SDGs. Without having one devoted, all the others contribute to it, but universal health coverage is an important one. And just to kind of set the tone, I just want to read out one sentence about universal health coverage, the way the World Health Organization talks about it. It says universal health coverage means that all individuals and communities receive the health services they need without suffering financial hardship. And it includes a full spectrum of essential quality health services. So it's a very simple idea that everyone who requires healthcare has access to healthcare without any huge financial hardship. That's the core of it. And of course, then the dimensions of how do you ensure it, as Shamal, you said, different countries have done it in different ways, and we need to learn from those. And we also need to look at our own traditions and what we have done here in India. And I feel the timing of this panel is also very, very interesting, because while as a nation, we may have paid a very stiff price under the pandemic, but this is the time that also saw a burst of ideas and approaches to solve the health crisis, whether it was in terms of use of technology or provisioning of infrastructure, or new ways of organizing supply of care, leveraging of community spaces, etc., etc. So I am really looking forward to the wisdom from this panel to shed light and guide all of us on how India's journey to universal healthcare can become faster and smoother. We will do 2 short rounds of conversation between the panel, and then we'll throw it open to the participants for their questions. So if I may, to begin, if I may call upon Professor Satya. Sir, you have studied this space both within India and outside India. If I may call upon you, sir, to speak a little bit about, according to you, what are the key issues that you will flag when you are talking about universal health access, particularly for rural areas, including if you would like to comment on, as Shamal already mentioned, how other countries may have solved that problem. So over to you, Professor Satya.
Thank you, Nilima. When an individual tries to access healthcare, there are several barriers to that. One is physical. So there's distance, there's transport, then there's social. There are gender issues, there are caste issues, even language issues sometimes. So there are many issues in terms of social norms. Then there are information and decisional barriers. Don't know where to go, what service to seek from whom, and so on and so forth. And finally, there's a financial barrier. What will it cost? Will I be able to afford? So broadly, these are the barriers that we see, and different people in different places face them differently. So an urban resident has much less physical barrier than rural. Rich people have less financial barrier than, say, poor, and so on and so forth. And to the extent people have ability to overcome these barriers, more health equality would come. So universal health care will contribute quite a bit to get health equity. So that is important. Now, from individual level to national level, macro level, there are some issues in overcoming these barriers. One is, of course, everybody has talked about it, is the India state and central together spend so little money compared to almost all countries, only 1 to 1.2% of GDP. And I think at least for 8 years, 10 years, I've been hearing that it should become 2.5 or more. We haven't made a whole lot of progress, although there's extra allocation for COVID. We don't know whether that will last or not. And we learned in COVID that we can set up facilities far more quickly, but manpower cannot be created that quickly. So this whole movement to really reform medical, nursing, paramedical, even frontline workers, education, and then not much talked about, but quality of care is an issue, social norms is an issue, so on and so forth. So there are a whole lot of these issues. Now you're asking, what have others done? Well, I think Shamal had said, I don't think they have a colonial masters anymore, but UK has provided both. There are two issues: service coverage and financial protection. UK does both. So NHS provides service and pays. Some countries provision, so they pay, but the services are by private sector. And some countries have varying mix of insurance, employer self-insurance, government buying insurance. So each country has sort of looked at its own context and figured out what it should do. And my view is that India will have to figure out its own. Right? And what has India done after national health policy, which asked for universal health access? There was Ayushman Bharat launched in 2018 with two parts. One was converting health centers to health and wellness centers by broadening service provision to include not only reproductive and maternal and newborn and child health and adolescents, but non-communicable diseases, communicable diseases, mental health, and so on. And about 150,000 such centers were to be upgraded. And this would be a critical channel for primary care to rural areas. And the second part was Prime Minister Pradhan Mantri Jan Arogya Yojana, which gives 5 lakh rupee per family, or the targeted families, about 40% of them, hospital insurance in a year. So that is supposed to take care of some financial protection. So these are the service coverage at primary level and then financial protection through PMJAY. It's too early yet to see how well they will work. COVID has further put of course, new ideas and so on, but put a break to this process. So it will take some few years for us to figure out how well they do this service coverage and financial protection. I'll come back to that in the second round to discuss this more in detail if you would like. But there's a long way to go, I want to remind. World Health Organization has an index, Universal Health Coverage Index, with 14 services and so on. And they rate that about 2 years ago at 55. So there's a long way to go. Financial protection is also a serious issue. About 50 to 70 million 5 to 7 crore people get pushed into poverty because of catastrophic health insurance. So it is a serious issue. It's going to be perhaps a long journey. So I will stop there and see if there are further questions, then I can take that.
Thank you very much, Dr. Satya. I think you just kind of opened the issue. But I would like to flag two of the points that you raised. Maybe we can come back to it when you come back again. One is, like you said, the financial aspect to it. And the second that you said, that the people upscaling, the trained personnel, whether that's doctors or care providers, how do we find a solve for that? So, but thank you very much, Professor Satya, for just kind of opening it up. And like you said, it's only so far that we can look at how other countries have solved it. We will have to figure out a solution for ourselves. And maybe that's the segue for maybe Neeraj to come in, because your organization, Neeraj, works a lot with systems, with governments, and you've demonstrated innovation and success in that space a lot. So if you could share some of the promising developments that you see on the road towards universal healthcare, which you would like to share this evening. Thank you, Neeraj.
Thank you, Nilima. And I just want to caution everybody, I'm the eternal optimist. So I'm finding good things in everything that's happening around me. COVID hit us. I am expecting, Dr. Satya, that next year we will have a much larger budget because, COVID has made health a political issue. Elections are going to be won and lost on health. So I'm hoping that that's going to finally happen. And I know we've all been waiting for that. What it's also done is it's shown us what could happen from an economic perspective. So, there's been a huge devastation in terms of the economy, in terms of industry, in terms of commerce. So again, health has become a very, very important subject from that perspective. And that's why we are seeing corporates, lots of organizations is jumping in and saying, how do we participate? And it's not about health of me and my staff alone, it's the health of the nation now. Because if you're not going to take care of that larger population level health, it probably will be a problem. In terms of innovations, I must firstly also admit that while we try lots of things, we fail more often than we succeed. So probably, Shamal, we're in the same boat as Mr. Hazarika. We are also trying to figure out what those solutions are. But yes, I'm going to today not focus on the failures. I'm going to focus on the successes so that we can actually learn from that. And Nilima, you said something, where's the money going to come from? That's an important piece. I know that all of us know, and I know that, I was looking through the audience, a very informed audience. So we know that 2/3 of our healthcare spend is out of pocket. So people are spending money to receive healthcare. Quality of care is a challenge, and that needs to be worked on. So private healthcare provision cannot be ruled out. And there I want to take an example of tuberculosis where, we've been talking about elimination of TB for the last 7-8 decades. We are finally probably reaching somewhere. We may not reach the target of 2025, but because there is a mechanism of public-private coming together, public funding the private, public also regulating the private, and really operating as one unit in terms of elimination of tuberculosis. And this was a program we ran it wasn't a small pilot, it was the entire slum population of Mumbai, got scaled up, now it's across the country, and we have managed to bring in about 2 million cases of tuberculosis into the system. They are being treated. We've got success rates in terms of adherence to regimes of about 70%. So all good stuff there. But that also tells us that there needs to be a public-private interface for all health services. And PMJ has kind of tried to do that. They've accessed private tertiary healthcare through the Ayushman Bharat PMJ program. Successful, not successful. I'm the optimist. I see the glass half full always. I think it's been fairly good. It's in the right direction. There are insurances which are kicking in. It's mostly working apart from some glitches here and there. But why can't we do that for primary care? Why, if 70% of the population is anyway going to private healthcare providers, Why are we not ensuring that there is a certain mechanism of doing that, and that we've done it in TB now? So that's probably the way forward in rural places also. And regulation is going to be absolutely critical, because once you go into rural areas, the challenge is that most of the healthcare providers are not certified, they are not trained, etc. So quality is going to be absolutely critical. I think that's the service innovation side of it, which is really how do you deliver services. And again, I don't want to wait for Ayushman Bharat to start setting up and how it develops, etc. This is the moment. We've got a moment where everybody is thinking and talking about health. This is the moment that we need to seize, and we need to move this forward very, very quickly. So that's the service side of innovation that I wanted to give you an example of. The other is the product side of innovation. We don't have enough healthcare people. Workers. We will never have enough for India. We're a large country. Let's not forget we've got a fairly large population, and that's why, for me, when we look at NHS, when we look at the US system, when we look at Singapore, it doesn't really match up, because we definitely can't go there, and we can't go the way China has gone either. So we'll have to build our own. But innovations on product, especially at the primary care level in rural, are going to be absolutely critical. We've seen what telehealth has done for us, positive during this COVID time. We are also seeing a lot of technological innovations which are helping with screening, diagnostics, etc. I mean, to give you some examples, we have artificial intelligence-based chest X-ray screening, which is now not only indicating for tuberculosis, but for COVID, other chest conditions, even going all the way to chest cancer, so lung cancer. So you've got these technologies where you don't need human interface. The technology itself can give you a lot of those answers. So if we are able to screen and diagnose much better at our primary care level, I think half the problem could be solved. Of course, then there's a referral system which doesn't work at the moment. So if you diagnose, it is unethical to diagnose and not then refer, and not then have that pathway for the patient where they go forward. So that's going to be another area which we'll have to work on. But we've tried a lot of technologies we've worked on. I gave you an example of this Cure AI one, but there are other technologies that could be used to help. We have another very interesting innovation. It's called Cyana Press. It's a self-injectable, so you use it yourself. It's a self-injectable contraceptives made for women, which protect them for 3 months. You're changing the whole dynamic of the decision making of contraception from the man to the woman, and the man doesn't even need to know. Huge shift it could have in our rural primary healthcare model. So I think we'll have to use a combination of service side innovations. We'll have to think out of the box. Let's not wait for things to happen in the public health system. Anyway, most people are not going to the public health system. So let's go to where the people are. And technological innovations that could actually help us really leapfrog over this challenge of not having the right kind of people, the trained people, and the right numbers. So I think that's where I would sort of focus. I'll stop there, Nilima, back to you and come back later.
Thank you, Neeraj. And that, of course, Ajay, is the perfect opening that you could have got, because if somebody's worked on technology, you have finding solutions which are technology backed for healthcare. So please do speak about that. And also I would like, Ajay, if you could speak about, how, what happened during the last 2 years because of COVID, what happened to the technology-based solutions? Did you get the proof of concept because you were thrown into the midst of challenging times? So how did technology emerge out of these last 2 years? But also, Neeraj, I want to, when we come back, because you, I think, opened up many things which are very debatable, and for example, the role of the private sector. And only because 2/3 of the people are not going to government facilities, does that mean that the role of the public goes down? Or so there are many such things that you've let loose in the conversation. But over to you for now, Ajay. Your remarks on the technology bit and yeah.
Thank you, Nilma, and thank you, Neeraj. I think that was a great segue. I agree with a lot of what Neeraj said, especially around primary care. I think, and if I may, I'd like to start at the top. I think that I'm similarly optimistic as Neeraj is. I think what we've seen right now is probably the greatest health emergency that our generation or last two generations have seen. And to me, this is it poses a model question to this country. It poses a question around what will we do about this. Huge shifts in health systems can happen at this moment if we all push to make it happen. And I think the other thing that I would say is that it's also been instructive in the sense that the middle class went through healthcare experiences that they usually sheltered from by money and class and many other barriers. So I think there is a sense of solidarity to some extent. Early on in the pandemic, I don't know if this phrase was thrown around, which is the pandemic is not over anywhere till it's over everywhere. And I think that's very, very true now. If you see the wave after wave of pandemic that becoming vaccine equity and all of these larger global health issues. So I just wanted to open with that because that's immediately what comes to me. I think in terms of technology, it has been, so technology is a tool, right? Like, so I think technology has by itself is growing by leaps and bounds, right? So there is great AI technology, machine learning, natural language processing. There's a lot happening in technology, but I think when it comes to technology and healthcare, what's important is not how good the technology is. It's actually where in the care continuum and in what kind of a care model is the technology embedded and what role is it playing is the more important question. And I think the problem in India is that we don't really have good care models at scale, right? So if you had a great primary care model, there are 500 things that technology could do to make it better. But when you don't have that, and when you don't have that model to begin with, then there is very little that technology can do. So I think that's one way that I look at it. I think what technology can do for India, if I look at the silver lining here, is that over the last 2 years, we've seen that doctors across the country have used telemedicine in one form or the other. And as I frequently, as we discuss, is WhatsApp is probably the largest telemedicine platform in India today because pretty much every doctor has done a consultation on WhatsApp. And so in that sense, a lot has changed. I think, especially around telemedicine, there've also been the telemedicine guidelines that were put out by the National Medical Council. So it formalized telemedicine. So I think from a telemedicine sense, a lot happened. But we also know that, there were app after app after app made around the pandemic, not just in India, across the world, which did not really, so it showed us both sides. I think organically we saw a lot of use of technology in the health system, but we also saw, how there were large promises made around all kinds of technology, which didn't really come true. So I think we saw both sides. And I think that is one thing that we should take back. I think very specifically about India, what technology can and should do for India is that, as Neeraj very rightly mentioned, primary care is key. I think what we've also learned in the pandemic is that, in a surge, you will never have enough hospital beds and hospital capacity. Your best bet is to manage people in the community. And that's what a good primary care system would have done had we had one. And which we didn't really have, right? So I think the lesson, there are many lessons for the pandemic, if that's one of them. Now, obviously technology can improve. And, I like Professor Satya's barriers to access for individuals. And I think technology can actually help on each one of them, right? So I think physical barrier telemedicine is actually helping. When it comes to the information asymmetry and the decisional barriers, I think what is also going to happen with technologies, there's going to be a lot better data out there not just for patients, but also for policymakers, program managers to make decisions. I think the NDHM is a welcome initiative. I think people should engage with that a lot more and figure out how that is working and engage with the system, because the National Health Authority is also working on the National Digital Health Mission, which is talking about interoperability of data across the country. So I think those are some key pieces. The other piece I would think about with technology, and this is already being, you also already see it in a lot of states, is the idea of task shifting, where you are able to shift specialized tasks down. Because if you think about how long it will take to create as many doctors in India as the country needs, it's a long process, right? It's a longer than a decade-long process. And then the other issue in India is not just the fact that we don't have enough doctors, we also have a distribution problem of doctors, right? So in urban areas, doctors are concentrated, in rural areas, they're not. So I think these are some of the challenges which are very unique to India that we can actually use technology for. But like I said, technology by itself will not fix any of these problems. I mean, I think the right models are needed that can then absorb and use these technologies. So I'll stop here and then maybe come back later.
So thank you so much, Ajay. Thank you really so much, because often I feel people oversell the possibilities of technology. And I really liked what you said, that if you have a model which can then work, then technology can help you take it to scale. If you don't have the basic building blocks, then it's hard for just to expect technology to provide those answers. And one of the biggest, I guess, missing building block, you of course spoke about the availability of trained manpower, the distribution of it, but also about community and community-based solutions and primary healthcare. So I would like to turn to Dr. Thelma now. And Dr. Thelma, what are your thoughts on, the kind of role that communities can play, community-based solutions, and also community-based providers, whether those are traditional healers or what are called the Jhola Chhap providers. Maybe Neeraj will say they are not qualified, not certified. I agree to all those challenges, but the fact is that they are there. Is there any role that you see for all of these people in this most critical missing piece?
Yeah, thank you, Nidima. No, I think, as many people know, I'm very much part of the Jan Swasthya Abhiyan, and I've also been engaged with the National Rural Health Mission and NHM, National Health Mission. Just that's where I come from. So strong belief in the health as a fundamental human right, which is enshrined in our constitution and in all international bodies. But it's more our own inner conscience that leads us there. It's not, we don't need an international treaty to remind us about that. So I think when we think in terms of rural India, is that health for human, the human right to health actually been actualized? Not fully. So we have to understand, what the barriers are, as Professor Satya was saying, and how do we get there? Now, a very brief recall of the Health for All of 1978, which had comprehensive primary healthcare as its strategy. Now, one of the key components of comprehensive primary healthcare was community participation and engagement, and that did lead to a whole lot of approaches. We had the famous community health volunteer scheme. It became later Jan Swasthya Raksha, Mita Anins, Ashas, etc. So we really tried this on scale. And in the NR, from 2005-06, actually communitization of the health system has happened on scale, and it's happened in every state and in every village, which I think is something that's important to bear in mind. So there is this huge human resource. There are about 1 million women. And now we can ask, is 23 days training really adequate? Not really. And is her career plan been thought through? Not fully. There have been very good modules made for the ASHAs, but again, the ASHA support system varies across the country, and I think we need to put in more money as well as more effort into the good quality education at that level, and of course all the way up and down it's required at the health and wellness centers, it's required at the primary health centers, taluk hospitals, district hospitals. The human resource, which is our human capital, our social capital built over the years, requires much more detailed attention, and the approach that we use there we talk about community engagement, but how are our health professionals, even in hospitals and health centers, actually trained to engage with communities, to respect the dignity of every person, their different cultural background, different languages, different caste groups that they come from? Is everybody respected? So one of the biggest challenges, and these are issues raised by communities, they prefer to die in their home rather than go because of the way they're treated. It's the attitude of staff. It's not just a physical barrier. I think Professor Satya did raise that issue. And I think we have every ability to address that. And I'm sure that in the next 10 years, we have to give ourselves this target, that in the next 10 years from this, we have to, and we will, we can easily reach that. So from primary healthcare, we came to universal health care, and then to universal health coverage. So what has happened in that process? We've actually forgotten about the social determinants of health. We moved from health to healthcare. So because health coverage is easier than in health status. Health status depends on all the developmental factors, whether it's education, housing, roads, transport. Then you have better health. So just providing medical services, curative, biomedically driven, will not increase the health status of people. It will provide care. And definitely in the COVID situation, we know the tremendous suffering people went through because they did not have access to basic medical care, to oxygen, for instance. So the health care itself is a determinant of health. So absence of adequate health care, creates a lot of problems, and people with long COVID and their whole families were affected, are affected for the long term. So this has been a huge learning. Now, coming to the positive sides of things, I think we've learned a lot. It's been like a huge learning for everybody. And the innovations that have happened have been positive. So even in mental health, the helplines, there have been Step One, maybe many people may have heard about it, or Sahai helpline. Technology has come in, telemedicine, telehelplines have come in, and the NIMHANS has a very well-used helpline. So I think it has brought out the creative and the compassionate, as well as capability-based response from a much larger sector, because in this case, everybody was affected. It cut across all class, caste, and everything, and our basic humanity came into the forefront. So there was this huge, which I'm sure will be captured by good documentation. Now, I would say that we need to carefully look at the financial aspects, because while out-of-pocket spending, it doesn't mean that therefore private healthcare is actually better. And what is the quality of care that the average Indian is actually accessing? It's very varied. So what the corporate sector offers versus what the small general practitioner it's extremely varied. So I think we need to make sure, if you're talking of all the aspirational districts, so I would say all over rural India, then we have to ensure that in that, what is the quality of care being offered? What is the quality of health professional education that's taking place in the mushrooming new medical colleges that are coming up? And, so I would just sort of last couple of points that I'd like to make is about accountability of the health system, whether it's public, private, or whatever. And I think systems have set up, and over the past 15 years, we do have experience of the community action for health, which includes social accountability using, the traffic signal approach. And there have been studies which show that where that accountability system, that it's not in every district, but where it has been introduced in PHC level or CHC, the quality of the services in those centers has improved when there is the accountability mechanism. So it helps to, those are like feedback loops which help to improve the care. And lastly, to your point about the folk healers, I definitely think folk healers have an immense role to play. And there is a transdisciplinary university here in Bangalore where this has been studied and documented a lot. They've also evolved very interesting accreditation and certification systems, which are community-based, which certify, folk healers. So there's a huge human resource pool available there, besides the entire Ayush spectrum. So I do feel that if you add all the human resources together and we take an all of community approach or all of society approach to addressing what we are trying to do in next, hopefully 10 years, we have to reimagine. My very last point is that our indicators, because I've looked at the indicators even in the aspirational district program, you go to the indicators, they're the same old things about MCH. That will not help capture what's actually happening on the ground. So I think we have to reimagine our health indicators too. Thanks, Nilima.
Thank you. Thank you very much, Dr. Thelma. I also, feel what you said about the local providers and healers. Health is also about trust. To one of the foremost dimensions, if you don't trust the person, if you don't feel respected, so that also acts as a barrier otherwise. So if you take, the patient out of that context and put him into something else, and we've seen that repeatedly, whether it comes into adoption of new practices or even vaccination. Currently, the kind of pushback to vaccination that has happened, it's because we did not take on board some of the community concerns or reservations or people who could move. So thank you very, very much, Dr. Thelma. And I also feel many of the things that you spoke about, of course, you spoke about all dimensions of health, but you also spoke about how health is more than just medical care. If you think about health, it is far more in wholesome and many more determinants. So I would like to go back to Professor Satya. And Professor Satya, if you would like to share with us. So I know there are many questions that have come up also on financing systems. If there is something that you can speak about that, or if you can speak about also the other issue that came up about health providers. Ajay spoke about the lumpiness in terms of their availability and the overall shortage. But any of these two issues or about the governmental, the recent policy. I know Professor Fansalkar has also asked a question to you on the RMNCHA. Is there too much excessive emphasis on RMNCHA? So over to you, Professor Satya.
Thanks. First, on the financing, 2.5% of GDP means the health sector should get about 5 lakh crore. Today, it gets about 2 lakh crore. 1/3 from center, 2/3. It gets more because of COVID. So if you remove all the vaccine and what other additional, emergency things are made, I wish I was as optimistic as I think I'm much older. That's the problem. But money will come. Question is whether it will take 10 years or whether it will come by 2025. So as the economy progresses, a larger share of money will come to health, which is experienced universally. And I think once you have 2.5 or 3%, your public sector services can be much improved compared to what it is now, because they are really malnourished, Okay, so I think it will come, but nobody can guarantee, except maybe in a 10-year frame. The other thing I want to say is that I don't want to send public and private against each other, because that model will not work in India at this point. And that's what many countries have discovered, that you have to look at your context and go forward. So I think there is an example on PMJAY, how good it is, we don't know yet, we don't have evaluation, where you can accredit private institutions and people can go to private and government under some rate structure pays for it under PMJAY. There are many, many models, none of them very smooth, I must say. In fact, if one thing COVID taught me, there's a long way to go for government to learn how to deal with private. Even in emergency, where everybody was willing, it was not all that smooth. Although there's one government and, the oxygen providers and not just medical, but all these other things. So the third thing I want to say is that, yes, it's going to take a long time, but you have to make a beginning somewhere for human resources. And you need to seek I'm not saying people are not quality, they have functionality, everybody has a role, but if you don't begin, you will not end. So one would have to do it. There's distributional aspects. South and West is much better provision. And the model was to open a medical college in each district, which is what Thailand had done 2-3 decades ago. And UP is now claiming it is doing, and others will do. But these are all 7 to 10 years thing, but it could happen. Whether it will make local and rural as much impact, I don't know. But I think we need to look at these two models quickly. One is the health and wellness center, because that's what government is not going to move away. Maybe new government will come in 2-3 years and I don't know what it will do. But generally, these are the two models that will move on. And so we have to see how best we can make them work. And about 40% of health and wellness centers have been set up. Not carefully evaluated, but people say they use telemedicine, they use point of care diagnostics, and various other things. They are supposed to also do community mobilization, help, we saw this comorbidity business, so help in non-communicable diseases, move beyond RM and CHA, which was the major thing. And this is a move to, in primary care, to much more broaden it. So I think that is happening. To end, my feeling is that, and it has been mentioned by Thelma and others, that whole society response will be required ultimately if we want universal health coverage. And that begins with self. So I think sign up, yes, and some self-care movement where people have to learn to take care of themselves as much as they can. And as women's education moves forward, I'm more optimistic that will happen. Just let me give you, it can be done. Let me give you an example of delivery in health institutions. 2 decades ago, only about 15%, 10 to 15% mothers were delivering in health institutions. Today, it is 85 to 90%. And all these barriers that I said were taken care of. 108 ambulance guaranteed, public sector, public facilities will not charge, even some big states mobilize private. So it can be done. I think it will be done. It's just the time frame is the question, and our path will be perhaps not so linear and straightforward. So thanks.
Thank you very much, Professor Satya. I really liked what you said, that maybe self-care is what, from where the journey should start towards universal healthcare. Neeraj, if we can come back to you, and I feel you made some very interesting remarks when you opened speaking. You said that at long last, health may become a political agenda, which we have all wanted it to become, and maybe we will see more money coming into it. But I want to ask you to connect that part, which with also the other part. Professor Satya also said that the public and private, we have to figure out the proportion or the balance for ourselves. But if you were to look at India and you look at other countries and how they have figured out the combination of the public and private, what would you say, what is the kind of combination that India should be looking at?
Yeah, thanks, Nilima. If I take the utopian view and look at and go back to thinking the way I am, which is from a socialist perspective, I would want the government services to be available for anybody who can't afford it with good quality. The challenge is the reality of the situation today. People don't trust the government system. That is why they're going into the private system. The private system is not regulated or supported by the government system. They're at odds with each other. You can try and either convince people to start coming to the public system, which means behavior change, which means also first getting the quality of services right before you can start the behavior change activities. And maybe I'm just sequencing that first you'll have to get your services right for that 30% population which is coming to a public health facility. Then you have to start doing the behavior change of trying to attract people to come in. We're probably looking at a couple of decades. We don't have that time. There's an urgency now. And I think we've had enough. And I think we really need to now find faster ways to get to universal health coverage. So from that perspective, while the government services definitely are going to get ramped up, are going to get supported, are going to be built, but I think it's going to be a combination of both. The private sector, both in terms of healthcare provision, in terms of a very important role that they could play is in terms of pooling of resources. We've seen that. We've seen organizations like ACT grants, like Give India. They've just come out of the blue. They've just come out from nowhere. And they've done really good work in the last in the last couple of years or last year and a half. This should be a continuous process. So I'm kind of saying that there needs to be, and they bring skills, they bring money, little money, not much, but compared to what the government brings, and that will still be needed. But it needs to be a combined effort. And I think that's where I was going. I'm not saying that it will be wholly private or wholly government, but I think if we are serious that in the next 5-7 years, we want to try and get to universal health coverage, there is, we don't see any other way. We are not going to be able to train enough people. We will have to work with the private sector system. There were some comments about doctors, Ayush doctors, homeopathic doctors. Yes, absolutely. We need to bring all of them in. They need to be part of that system. But regulation needs to come in, quality control needs to come in, and that's probably a role that the government could play very well. So the carrot and the stick approach of saying, we'll pay you for these services, but if you mess around, you go to jail. So I'm being a little extreme here, and maybe that balance is required. But for me, that urgency is critical. We cannot continue to wait for the public health system to get going and for people to start moving into that system. I'll stop there. And sorry for the controversial commentary, but I feel very, very strongly about it. Thank you.
No, Neeraj, most useful, because if we are not going to have this conversation here, then where else? But let me turn to Dr. Ajay, and I know there have been several comments here which kind of, echo back what you said, Dr. Ajay, about, how technology could help, could not help. But do you see any downside, and especially in the last 2 years, what kinds of limitations to this? Some you already hinted at when you spoke earlier, but what are the other kinds of, if there are any things that one should watch out for? Could it lead to further distortions? Could it lead to greater, could it lead to increasing the inequities in health access? So any thoughts, Ajay, on while we all love technology, but what is it that one should be careful of when one falls in love with that?
I think, one of the things that sort of immediately come to mind with technology, and again, it's hard to have this conversation with, in a community where there is very little healthcare. But what technology also does is that it just makes a lot of data available very, very easily. I think, and again, which is the reason why I think that we should engage with this with the policy dialogue at the National Digital Health Mission, for example, because they are talking about a consent architecture. They are talking about giving a lot more control to the patient, because what technology will do is that it'll just make a lot more data available. So there is, there could be severe privacy and security concerns if you don't think about this properly. The other thing I would think about is that technology, you can use technology in multiple ways, which is why I said that it's important to think about the right kind of care model. So one could use telemedicine, for example, and be extremely transactional. And I don't think that's the kind of health system we want. So I think, just being careful about things like that are immediately things that I would point out to. But I think, again, it's not so much the technology itself. But the technology is like a doctor has a hammer and a stethoscope, and the technology is a new kind of hammer. But if the doctor doesn't know how to use it, then, what's the hammer going to do? Or if, the hammer is used wrongly, then it might cause harm, right? So I think it's less about the tool and it's more about the system that's using it. And, I wanted to just go back to Neeraj's point, which is that we have to work with what we have. Health has been, and I understand health is political, and I understand, it makes sense for ideologies to be there in health. But we've been very ideological about health in India. The private sector doesn't talk to the public sector. The modern medicine doctors try and block the Ayush doctors from doing a bunch of things. We are playing these games when there are millions of people dying. And I just feel like enough already, right? Like we've gone through 70, 80 years of talking about this and having all of these lobbies fight each other. But again, this is a model question, right? Can we move past all of that? Can we work with whatever's in the country? And again, echo exactly what Neeraj said here is that, we should be very impatient about this.
Thank you. Thank you very much, Dr. Ajay. Coming back to you, Thelma, you are the only one holding the flag for the community. Of course, Professor Satya moved it beyond the community to the self, the first nucleus, the atom of the community. I just wanted to go back to that, Thelma. What kinds of, if you could share with the participants, one or two examples of where you have seen these community-led approaches really helping with these last few, the last mile, or the power of bringing the community on board in this universalization agenda. So just one or two examples that you can, it'll just illustrate the point, I think, much more strongly, that if you don't put community in the center of finding these solutions, it'll probably be incomplete.
Yeah, no, I am a strong believer in the capacity of communities and the individuals within the communities, because the communities are comprised of individuals, families, and the communities, and they have a lot of it's irrespective of their educational status, they have abilities. Now, to give you a very small example from the community where our team is working, I mean, we're doing even toilet construction and things like that. The community said that there is no electricity in the neighborhood of the toilet. And for girls and women using that public toilet, because they don't have individual toilets, even I'm talking about Bangalore city, very high-tech city, Silicon Valley of India, but they are very close to many, So the community themselves ensured that the electrical connections and lights were repaired. They heard the voices of the women and girls in the area, and they themselves got it done. They used all the local frontline workers from the electricity department. Now, this was a health intervention, by the way, but it led to working with the electricity department, the linesmen, and all of that getting done. And there's a community accountability group which does that. So also ensuring that the toilets get repaired. There are land issues around toilets, where they're located, etc. So it does work on a micro level and also on larger levels. So going back to the earlier experience with the village health and sanitation committees, when they were given that small little untied fund, which actually very often was underutilized, because the untied funds come so late, in the financial year, many of them cleaned the drains and the overhead tanks. This was a health fund. And the communities themselves, after discussing in their local groups, actually decided to focus on drains and overhead tanks because that was their priority. And that actually would have helped the wider community to improve the conditions of living which impact on health. So the mental health consequences of not having access to basic sanitation is huge. We've done studies, small little studies, which are interns. We have a big group of community health interns and fellows, all drawn from communities across the country themselves. And they are able to communicate in local language, as was brought up here. And the mental health issues, the tension, the anxiety, the even depression, suicidal thoughts because of lack of access to toilets, and then how the communities can actually ensure that access to, but that's a health action. It's as important as providing ORS or antidiarrheals or technology. I want to also say another thing, that health, all of us, let us think of our own health when we're talking of self-care. When we are ill, we are in need of comfort, care, and healing. A technology tool cannot provide that hand, the touch, the loving voice, the tender loving care. We used to all joke when we were medical students that TLC was the best medicine, tender loving care, so which homes produce. But Ashas are phenomenally good at doing that, because it's a natural instinct. But if they're provided that support, that caring nature, which is there, it's innate in definitely in India, it's across the world, but we have that. So I think I would say that the Ashas have played a phenomenal role in the COVID context at great cost to their own self. They've shown courage, and a lot of their payments have been delayed. Their compensation has not been given. Their insurance has not been covered, but they've still gone ahead and done it. What is it that makes them do it? It's not the technology. They have also learned the technology, by the way. They use pulse oximeters, they use mobiles pretty effectively. They learn from their children and use. So those are also community led. So children teach their parents, accompany their parents in this work. Even in reading some of the manuals, there are quite nice, very good manuals prepared. Sometimes the children, because some of the Ashas are not fully educated, the children help them. So it creates, so these are just some examples of community.
No, thank you. Thank you, Dr. Thelma. I also feel that during the pandemic, I think it was the communities that played a huge role. Otherwise, the tragedies could have been worse. And hopefully that energy that got generated and examples that came up will be built upon. I have not been a good moderator, and I know there's so many questions. Each question actually will require long conversations, and maybe we haven't addressed them. I'm truly sorry about that, but I'm hoping that at least some of your questions would have got answered. Shyamal has offered us another few minutes to wrap up. And I would like to wrap up by just asking the panelists that for a minute, assuming that you have all the wherewithal at your command to set the course right towards universal health care, what are the top 1 or 2 decisions that you would take, or top 1 or 2 priorities that you will pick, which will help us reach that goal faster? So with those remarks, we will then close. So Professor Satya, would you start and talk about your wish list, the top 1 or 2, which you think will really help our journey very strongly?
I think they should make more money available to health sector than they have been doing so far. And how sooner they can do it, better off we will be. Okay, so then I think wheels will move.
Oh, fantastic. Thank you very much, Dr. Satya. Neeraj, the genie is giving you 1 or 2 wishes.
You should have put a max cap to that. This is the maximum you can ask for. But I would definitely say that if I could, I would really focus on large scale screening and diagnostic of our populations. We need to catch them in, close to home. We need to catch those diseases early, and we really need to deal with that. So that's what I would say. That to me will lead to better, primary healthcare and better universal health coverage.
Oh, fantastic, Neeraj. That's a new wish. Dr. Thelma, what is your top wish?
I would also say financing is the most important. I have 2, financing and human resources, the training. But I would say the distribution, one is the source of funding. Where is it going to come from? That was the question. I think definitely public sector has to increase its, contribution to this. But I'm also completely with this idea that actually private sector and all other, philanthropies and volunteer NGOs, etc., have to put in, and they are. So the barriers to NGOs in functioning also need to be reduced. So the financing requires absolute foremost attention. We cannot achieve UHC with the present funding that we have. 2 is the human resources require very detailed look from medical education to nursing education to every, health workforce cadre, including the ASHA. So these would be my 2.
Thank you. Thank you very much, Dr. Thelma. And maybe if I were to add mine, I would say that, we really, at least if there's one thing that I learned in the course of the work that we did, a lot of work with JPAL around health. One thing that I learned is that apart from the supply side, there are constraints on the demand side to reaching that health, overall health goal, not just supplying health, but having healthy people. So on my wish list would be some mechanisms of engaging with communities, empowering communities to make them participants in this process and not just recipients in the process or in the objective of achieving good health. But I really want to thank each one of you for this fantastic conversation. I honestly, one, of course, thanks to TRI for picking this issue, but also I feel that this is a conversation that requires many more kind of deep dives into specific dimensions of this problem, which I'm sure will happen. And thanks a lot to all the participants, and apologies if we didn't address all your questions. Thank you very much. And over to you, Shyamal, back to you. Thank you.
Again, I have nothing to add here. Thank you very much for joining us today in this evening.
No more songs.
No songs, but if you remind again that Tirukural had said that 5 are the ornaments of a kingdom: absence of disease, wealth, fatality, happiness, and security. I think to this evening has started a new discussion, and again it has been started on August, and again that August is the time of the growing up. So we thought, and reminding the forgotten forever. So I think that things which we have been committed many years back, universal health access. So again, we have started discussing, and we think that it will be starting a new small footprint towards the rural India. And again, the Tirukural had said that when the rare chance comes, seize it to do the rare deed. I think COVID has given us that rare chance to seize it, with that backed up with that the many things which we have discussed today. Thank you very much, all of you, to join us. And again, we'll hope that it will not end here. So now the marching will start. It is the only discussion. Thank you very much.
Bye. Thank you.
Thank you.
Thanks
Thank
so
you.
much.